Okay, thank you very much indeed to the KDIGO team for inviting me to speak. My name is Richard Fluck. I'm a renal physician based in Derbyshire, and I've been given a number of tasks today to talk to you about. First of all, I think it's important just to go through some of my disclosures, and there's the usual financial and academic ones to go with that, but I think it's also worthwhile bearing in mind that I have a role in the commissioning system within the National Health Service in England, and that might give me a perspective that is unusual from someone in a clinical facility, for example. So it's worthwhile bearing that in mind when you listen to me. In terms of the outline, it's a pretty broad outline that I've been given. I was asked to speak about drivers influencing home dialysis uptake, the influence of policy on home dialysis rates across the globe, and then finally the enormous question of what is the ideal modality distribution. And I think it's fair to say that I'm not going to be comprehensive because I cannot be comprehensive about such an enormous scope to talk about. But what I'm going to do is use exemplars and pose questions to start the debate rolling. And I think it's also fair to say that I'm talking perhaps with my own personal perspective in places. So the questions for us is how and at what level can we influence this home dialysis distribution? And perhaps the first thing I would say is that you cannot understand the distribution of home dialysis in isolation. What you've got here is a simple cartoon that represents renal replacement therapy, and we have the elements of transplantation and the elements of in-center hemodialysis. And as you'll see later on, there are other elements that feed into the pathway of care that people with kidney disease have. And so you cannot interpret in isolation rates in either peritoneal dialysis or home hemodialysis without considering how that healthcare system or policy directs people to other potential modalities or indeed the prevention agenda. But what we can say, and this is based on my experience over the years, is that whilst we as clinicians focus very much on the individual care of a person, and that can influence how you advise them and how you look after them in that shared decision-making process. But there are influences both at facility level and indeed perhaps at more local population level, and then further up the chain into national and regional agendas that can drive the process. So just to cover off some things that perhaps are outside scope, but I think we have to accept that there are things that are particular and unique to a particular healthcare setting. So for example, there is the basic things of availability of power and water, which may influence how you can undertake renal replacement therapy, the infrastructure of logistics and supply chain. We've seen that in the COVID crisis, the influence of logistics and supply chain affecting how we can respond, as well as the issues about availability of equipment and consumables. And then there's also the big question of affordability. So where does what we're doing fit into the context of national health and well-being priorities? And those implicit within those is the fact that there must be different challenges in high, medium and low income economies when we put these agendas against wider agendas. And then I'd finish off by saying there's also an issue around acceptability. And by that, I mean cultural acceptability in terms of what we deliver and how we do that. And those are things that probably we don't study well, but we need to think about carefully when we are configuring our systems. So let's just start off with some very simple data, but yet it tells us some important things to think about. So this is taken from the UK Renal Registry report of a couple of years ago. In some ways, the numbers themselves are not the important thing. What you're seeing here is a number of countries ranked by performance, if you want to call it performance, around home dialysis, where in-center hemodialysis is in the light green, red is peritoneal dialysis, and home hemodialysis is the light blue. And you can see there is instantaneously, you can see there is marked variation between countries. So at the far end of the less scale, we've got places like Japan and Indonesia, which have low rates of home utilization. And then we have places such as Mexico, New Zealand, and Hong Kong, which have high penetration of home therapies. But if you try and look for a pattern within that distribution, based on some of those factors I've talked about, I think you'll be hard pressed to say that a particular style of economy actually tells you where someone should sit. So let's pick out the United Kingdom. Here's the United Kingdom, sort of in the lower second division, if you like, of home therapies in terms of penetration. Here is the US in the middle of the distribution, and I've already talked about, for example, Japan, and you can look at Israel as well. So areas of high income, and yet they've got very different delivery patterns. And what this doesn't tell us is about that wider context. So it doesn't tell you about the scale of the overall program or the utilization. It gives you no insight into the potentially competing risks of transplantation. And it doesn't tell you about the economic availability of various modalities. And I'm sure listening to this, you in your own countries will understand that and resonate with that. So what about national policy drivers? I mean, how do they work? Well, in terms of health systems, I think there are two broad things that we can think about. The first of all is about target-based priorities, where you just say, well, you're going to achieve a certain percentage of people on home therapies. And I'm going to try and argue that I think that's possibly the wrong broad approach, although it may be a shortcut for your vision or your objective. And then there's a more thorny issues of, can you bring in financial incentives to try and guide, in inverted commas, people towards a particular pattern of therapy. And then we also have professional groups. So KDIGO is such a professional group to provide guidelines, to both influence health policy, but also to guide clinical teams. And I would also put within that professional group patient groups, so other stakeholders who have a view. And then perhaps behind it, there are some things around improvement science that we might touch upon. And then we've got sort of bigger, wider policy agendas. So the issue of equity is very hot in the United Kingdom at the moment, off the back of the COVID pandemic, and thinking about how demographics, for example, age, comorbidity, ethnicity, and the very important question of health literacy play into this agenda. And finally, we have the role of technology. And I mean technology in the broader sense, not just a machine that does things differently, although that is very important. But technology is an enabler which allows us to improve outcomes, influence the change process, develop sustainability, both in terms of the microcosm, in other words, your interaction with the patient, but also the macrocosm, so sustainability in terms of green agendas and economic value. And then also this business around the underpinning importance of communication and knowledge transfer between individuals. So let's get into some hard detail to just open up this debate a little bit. And I'm going to give you on this slide two examples. So on the left-hand side, you've got the United Kingdom, and on the right-hand side, you've got Thailand. And I'm going to pose a provocative hypothesis, my null hypothesis, that the overriding drivers affecting uptake and distribution of renal replacement therapy are based around national infrastructure investment and the role of private provision. So that's a provocative statement just to kick off with. And I'm not saying that one is good and one is bad. That's not what I'm saying, because as the examples will develop, you'll be able to draw your own conclusions. So on the left-hand side, you've got the United Kingdom. These are data taken from the registry. These are data that go from 2000 to 2015, and you have got 5 lines there. The red lines at the top here represent in-center type dialysis, and the squares are what a true hospital hemodialysis, as we consider it in the United Kingdom. And we've got, with the circles, we've got satellite provision. Sorry, I've got those the wrong way around. That's a bad miss, but let's just convert your understanding the other way around. And then in the blue dots, we've got peritoneal dialysis, and the triangles there are CAPD, and the circles there are automated PD. And then at the bottom, we've got home hemodialysis. Now, the challenge in the United Kingdom was one of provision. If we go back to the 1990s and so on, it was felt that we didn't have enough people on dialysis. we were overusing PD, and there was a resourcing issue. Now, the solution for the United Kingdom was to invest with the support of private providers subcontracting into the NHS for hemodialysis capacity within satellite services. And the impact of that can be seen with this line here. You can see the growth in satellite provision. So it makes up nearly a quarter. And with that, you could see a relative fall in hospital hemodialysis, although the absolute numbers remain the same or grew. But you can see that it had a marked effect upon the provision of home dialysis. So COPD penetration fell markedly and the absolute number fell as well. What is interesting is APD didn't shift. And in fact, it's actually switched over so that APD is a market leader in terms of peritoneal dialysis. And you can see in recent years a small growth in home hemodialysis. So the impact of the equity issue, the provision issue in the United Kingdom was to invest in center type programs and build satellite provision. And that actually competed against home therapies. And so we had a massive dropout in home therapies. And we'll talk about some of the policy drivers in a moment as to whether we've been able to influence or reverse that in some way. Let's contrast that with Thailand. So Thailand had an equity issue that they were under provisioned again for end-stage renal failure programs, but they developed their PD first program. So they cut their cloth accordingly, and they were able to drive up the prevalence of people, as you can see, over the last 5 years or so in this graph. So similar time frame to here. And you can see the incident number also going up from that point of view. So they had a different experience that this prevalent drive was largely based around a home therapy program, but the driver was provision and need rather than home therapies itself. So that's an important context. We've got a high income country where they have a provision problem and the solution is to build more in center and therefore home dialysis drops off. Whereas we've got a low to middle income country where the equity issue leads to actually more home dialysis. And you see other examples of that around the globe, such as Mexico. So what about the United Kingdom? What were we doing in that interim? Well, we sat on our hands. So during the period I've just shown you, NICE, which is our guidelines body, have produced three guidelines around dialysis. 2 directed purely against home therapies, and a more encompassing one that was published a couple of years ago. And then actually, I just put this as a little aside. In the COVID pandemic last year, we did write emergency guidelines for NICE, which actually emphasized the thought that perhaps we should be putting more people home to reduce their risk. But the bottom line is that this had no impact, particularly on the trajectory. We carried on as clinicians doing what we'd always done. So we'll come back again to explore why that might be in the United Kingdom context. That was coupled with efforts by the stakeholders. So this report was written in 2013. This is an all-party parliamentary home dialysis manifesto sponsored by the National Kidney Federation in the United Kingdom, which laid out a number of very sensible principles around the provision of home dialysis, and it had no effect upon the numbers. And we've just recently had the NKF provide a revision. It's brought in some additional data, and it's used the COVID pandemic to try and influence the debate. So let's turn to another policy initiative and just ask ourselves some questions around that. So that's the US Advancing American Kidney Health Program. And I think this is interesting because it's the principal driver is cost here, huge cost to the end-stage program in the USA. And its vision is actually broader than just home therapies, but home therapies are one element of it. It's to reduce the incidence of end-stage renal disease, double the number of organs transplanted, and increase the prevalence of home dialysis. And the mechanisms that they're starting to explore around incentivization and payment. And this is a graphic that summarizes it. Now, clearly, it's too soon to see what a free market economy with a lot of private provision makes of this, but I think it's interesting to see that Fresenius Medical Care had a press release at the beginning of this year that reported specifically on a 14% growth in home dialysis treatment and a 37% increase in home hemodialysis. So clearly, as a major provider in the US market, they've listened to this and they're moving their goalposts around this particular area. So those are some of the sort of national things you might want to think about. What about variation within nations or regions? So again, let me show you some data from the UK. So this is my home patch here in Derby. These are years from about 2012 up to 17 or so. And this is the percentage of dialysis patients on home therapies by the provider centres within this neck of the woods. So covering a population about 15 million or so. And there are a number of things you can pick out from this. First, there is variation. So there's variation in terms of home therapy rates ranging from 10 to 40%. So something like a fourfold variation. I can tell you across the UK, in fact, there's tenfold variation. But the second thing is that no one ever really changes. So we actually haven't introduced a methodology within the UK yet to successfully change the dial and actually get more people home for reasons that, you know, we again perhaps ought to consider and think about. I'm going to be a bit parochial and just talk about my home patch. So I'd like to say the top right-hand corner is my office, but that's actually Chatsworth. So I don't have an office there. It'd be lovely to have an office there. But this is just our home program within the Derby unit. And it's not to blow a trumpet, but it's to just talk about some of the principles. We're, as you saw from the previous graph, at the top end of provision. So we're 35 to 40%. And we've got a program of 65 currently on home hemo, 69 on PD, 206 on in-center hemodialysis, and 39 on satellite hemodialysis in the unit we've just acquired. And I think our principle has been about thinking about process as well as the actual direct clinical care. So we thought about how we recruit people, how we train them, and how we retain them on therapy. And that's a composite of leadership, engagement with the entire team within the facility, use of technology, understanding our process, agility and flexibility in terms of how we approach problem solving, integration so that it is one mantra for the entire service, from clinic through to the dialysis facility, through to the ward, through to transplantation. And very importantly, this concept of data utilization. That's what DICAR stands for. So the acronym stands for data. You turn that into intelligence. From that, you generate knowledge. You respond and you assess it, and then you review your processes and you change. And so hopefully on this slide, you can see that in this particular year, 2017, we started on 42 on home hemo, and by the end of it, we were just over 51. But within that, there was a lot of noise. A lot of things happened. But we trained 23 people. We transplanted 6 people. 2 went back to in-center hemodialysis, 1 for frailty, 1 for cocaine addiction. 5 sadly passed away, and 1 failed training. And we looked at our deaths, and we analysed why they failed. So we think very hard about the different bits of process. And again, it's a theme I'll perhaps come back to shortly. Okay, so do we understand variation within systems? So think of the country as a system and your healthcare that you deliver there as a system as a whole. And the challenge would be that if we had a national system that was perfect, you'd expect to see minimal variation between providers, variation that you could understand based on demographics or particular issues, but it would be minimized. And I think actually a perfect system would not be one of necessarily of steady state, but one that gave evidence of continuous improvement in the broader sense. So there are ways in which we can think about what is good that may be just more than how many people we've got on dialysis in particular modality. But that sense of continuous improvement at the coalface, I think, is very important. And my observations from going around the globe and talking to clinical leaders in a variety of countries and across the UK is that you can start to tease out what characterizes high-performing facilities. I think the first thing is that they have a clear vision of what high performance is about, as I've said. And that includes the concept of thinking about balancing measures. So unexpected harms that you might create within the system and monitoring those. I think it's about a good leadership structure that includes patients and the broader healthcare professionals. So some of my best advocates in my home hemo program are very junior members of staff or patients who advocate and they support others. I think it's about getting the right cultural situation right. It's about that powerful shared vision, and it's also about introducing concepts such as shared decision making. So not patient choice, which I think is a shortcut, crude way of thinking about it, but a real dialogue between clinical teams and the individual to come up with a better plan at any one time. And then it's about getting your internal systems right. And then this big part of culture, which is to have an improvement rather than a target mindset. We want to do better every day. And I think, if we're just talking about home therapies, I hope you can read this, but, in terms of primary drivers for increasing the proportion of people on home therapies, it's quite a simple equation. You want to increase the uptake and you want to decrease the dropout. And certainly you want to decrease bad dropouts, so dropouts to other modalities. But there are a whole load of factors that you feed into that process. So the final bit that I'm going to sort of cover off is that really thorny issue of the optimal distribution of home therapies. And I'm going to say it's a number somewhere between 0 and 100% of people who are currently on dialysis. And that might seem a bit glib, but I think the issue is that if we get into a target-driven culture too soon, then that actually can be a problem in a system to achieve that target. Because those who feel disenfranchised might actually opt out of an improvement process. So I think when we think about that question, I think you've got to think, what do you include in that metric? One of the criticisms I had back about my own program was, well, you don't do transplantation very well. And, I'd perhaps disagree with that, but I can understand where that's coming from. It's what you include in the metric of success. And so I think transplant must be in that box that we talked about, home therapies, but what about shared care within the center? Assisted PD, where does that fit? In-center hemodialysis. And this idea that we need to get away from competition between modalities and move towards synergy. I think those are, again, very important principles. The other thing is that I've shown you facility level data, but we need to focus on a population basis, not on a facility. It's a bit of a no-brainer to say that in some ways, but I think we need to realize that we serve populations, not maybe our institution. And therefore, we need to ask ourselves some questions about whether we provide equitable support to the population we're deemed to serve. I think we then culturally need to move from the judgmental measurement systems that we can have and measure to improve. So it is part of the way in which you challenge yourself internally to move forward. And we need to measure to improve value in a broader sense. And that's a composite of patient, clinical, and resource outcomes and process, plus, as I said, those balancing measures. And I'm going to pose a final sort of bit to that, which is perhaps the focus should be not on the target per se, but on the transition point. And so this is my sort of wider schema, if you like, in my last couple of slides to sort of finish off. Here is the box that we've been talking about. This box, which is CKD, should be huge. It should encompass the whole page, because obviously, if you're doing this well, then these boxes should be getting smaller because you're doing a great prevention agenda. The low clearance phase is important. We have this issue about conservative or non-dialytic care. We have end-of-life care. And all of this is feeding a patient pathway that is moving people from independent existence through to a degree of dependency. And how do we configure our therapies to fit that? But I would say where we get it wrong is we rightly focus on the care within these boxes, but we sometimes forget about these interface issues. How do we know that someone is failing on a therapy or needs to move to a therapy or a modality, and plan that effectively to give confidence and quality? And so I think we need to start thinking how we work these agendas in the context of those transition points. So let's just finish up with some of the how. How do we build it? And I think it requires all three of those levels working together. And it's about top-down vision, but bottom-up implementation. So guidelines from the top should not be recipe books about how best to do it. They should be about the objectives. And as a commissioner clinician within the NHS, I feel my job is to provide the right tools so that people can utilize those. So this is our change model that we use within the NHS, the shared purpose within the middle, and this idea of leadership, engagement, using the appropriate system drivers, good measurement, rigorous, thoughtful delivery, using improvement methodology, and then that important other aspect of it, how do you spread good practice within this Donabedian model for quality care with those measures and those balancing measures and that driver diagram. So where to next? So I gave you an answer of 0 to 100% for the number of people in a particular box. Let me just finish off by saying this would be my view of what the UK should be aiming for in terms of the box that is end-stage renal disease, perhaps as a challenge. I think that what we want is we want to see more transplantation. And we're already at 55%. We should be 60% plus in terms of renal replacement therapy as a minimal target, as we like. I've used a T word there. I shouldn't have done that. And then I think it should be actually within the dialysis modalities a 50-50 split. Now, the interesting thing is that actually brings us to a number pretty close to the US plan, which is to have 80% of people either transplanted or on a home dialysis therapy. So I think it's within our grasp to do that. And I think we do that by delivering this national value agenda, focusing on the facility and population through QI, and then as clinicians, as clinical teams, we focus on uptake and retention for individuals. So you need all three of those bits working together. So I hope that made sense. It's always difficult talking to a screen, but I'm looking forward to the rest of the meeting. Thank you for listening, and questions, comments, and brickbats are always welcome. And I'll stop there. Thank you very much.